welcome to this webinar, not webinars. I guess we're off to a great start, aren't we? So used to webinars. So welcome to this symposium on getting to grips with non-invasive tests to assess liver fibrosis and patient eligibility for novel MASH therapies. So just a few housekeeping rules. Use whatever you got, but we are offering an interactive experience through this live event. And use your cell phone or anything that has a camera. There's a QR code. You can use that to access the event, to view slides and look at the content, ask questions. Very important. Please do ask questions and participate in polling. You'll also be able to get CME at the end of the program. And the Wi-Fi network is AASLD with the password MASH 2025. So my name is Arun Sanyal. I'm a professor of medicine at Virginia Commonwealth University School of Medicine in Richmond, Virginia. And I'm joined today by two very distinguished faculty members. One, to my right, Professor Meena Bansal, who is a professor of medicine and chief of the Division of Liver Diseases and director of the MASLD Center of Excellence at the School of Medicine at Mount Sinai in New York. And on my left here is Professor Quentin Anstey, who is a professor of experimental hepatology and who's an honorary consultant hepatologist and at the Center for Translational and Clinical Research Institute Faculty for Medical Sciences at Newcastle University in the UK. We'll cover several topics today over the next 90 minutes or so. Starting with an overview of where we are with this disease that we now call MASH and what the rationale for its current therapeutics are. Talk a little bit about the emerging therapies, but then dive into how do we assess who should be picked to treat with drugs and how do we follow them, and really get into details of how we use these non-invasive tests in the clinic to manage our patients with MASLD MASH. And then we'll wrap up after questions. So let's get started now. And so just to further introduce the topic, some of the things we want to talk about are the prevalence, the key epidemiologic things that you as a clinician should know, and really talk a little bit about the consequences of disease progression and what that means for our patients. So these are data from Zubair Younossi, where we look at the global prevalence of MASLD. And you can see that here in North America, approximately 31% of the general population has, and this is an old paper, so it says NAFLD, and as you know, the nomenclature changed a couple of years ago from non-alcoholic fatty liver disease to metabolic dysfunction-associated steatotic liver disease. We use this somewhat interchangeably now, but 31% prevalence in North America, and in Asia, around the world, around 30%, give or take a few percentage points up or down. But there are hotspots around the world which are particularly at risk, especially the areas in the Middle East, in Latin America, that are really concentrated areas where there's a lot of steatotic liver disease, a lot of metabolic dysfunction. Now, much of this is linked to obesity, but it's also important to remember that you can get steatotic liver disease in the absence of obesity, and up to 20% of all patients with MASLD actually are not obese using the BMI standards, although they may have increased visceral adipose tissue, et cetera. Now, coming back to the liver, there is sort of a progression of disease as, imagine the liver going on a journey. Not a great journey because the destination is cirrhosis and hepatocellular carcinoma. But the milestones on that journey and that road is really first the development of injury and inflammation, which is steatohepatitis, which then leads to scarring of the liver. and progressive scarring leading to cirrhosis and liver cancer. And it's when you develop that cirrhosis, that's when much of the badness that is liver-related that occurs. Prior to that, many of the consequences are felt outside of the liver. What I mean by that is the liver makes a lot of cholesterol, liver makes cytokines, it affects your vascular health, and you're more at risk for cardiovascular diseases. So before cirrhosis, cardiovascular outcomes are the major form of outcomes once you get to cirrhosis, and the lines cross once you get to bridging fibrosis. So the key to assessing the patient in our clinic is really to understand where they are in this journey, because your risk profile changes as you go along this journey. So we know from healthy to steatotic liver, we talked about 30%, then there's back and forth between going from fatty liver to steatohepatitis, but overall, if you have steatohepatitis, over time, about 20 to 25% patients will progress to cirrhosis. And that journey is marked by fibrosis. And we assess historically how that happened, what's going on, by looking at the liver biopsy, right? The problem is that a liver biopsy can be incredibly expensive. It is invasive. It is uncomfortable, if not outright painful for some people, and actually can occasionally cause severe morbidity and even rarely mortality, which for a diagnostic test should be a never event, right? Hopefully we can all agree on that. So there's a whole slew of diagnostic tools that have been developed, from simple bedside elastography-based tools and to more advanced MR-based tools, but these can also are pretty expensive, and the patient has to go get these things done. It cannot be done for all. We talked about 40% of the general population. It's very hard right now to conceive having all these tools available for 40% of the general population who might need to be evaluated. So that brings us to using other kind of tests that we can do at the point of care, and we'll really get into this. This is sort of a central focus of what we're here today to talk about. But we'll place this in perspective by talking about sort of how all this fits into the larger management of the patient, understanding that the liver disease does not really occur in a vacuum. It occurs in the context of multiple metabolic comorbidities, which are frequently present in our patient. And where the field is moving towards is really thinking about the patient as a whole and not just looking at them individual organ-wise at a time. And this is based on genetic and environmental factors. Whole slew of genes have now been identified. Of course, PNPLA3 and TM6SF2 are the best known. And then, of course, there's diet, lifestyle, other factors, and comorbid factors that determine this progression that we talked about previously. Okay, so with that in mind, now let's just talk very briefly about the basic pathophysiology and the rationale for how we currently approach pharmacological treatment. So this is a simplistic 4-step model of how the disease in the liver develops. There's obviously detail around each of these pieces, but it sort of covers the broad scope. And it really starts with in a background of insulin resistance and systemic metaboinflammation, you deliver excess fatty acids and glucose to the liver, which in the context of all these inflammatory soup from the adipose tissue that the whole body is bathed in, then drives the metabolic, puts the whole metabolic machinery of the liver into overdrive, creating cell stress. And if the cell is stressed enough, it kills the cell. Along the cell stress, cell injury, cell death cascade, there are products that then trigger the innate immune system, and you develop a sterile inflammatory response. Over time, if this inflammation continues, the liver tries to restrict this by putting scar tissue down, and you get fibrogenic remodeling of the liver, eventually leading to cirrhosis. Now, 2 points. First, it turns out the same mechanistic cascade plays out in the kidney in the form of chronic kidney disease, in the myocardium to lead to heart failure with preserved ejection fraction, and in the pancreatic islets, eventually leading to islet loss and type 2 diabetes. But these 4 pillars or gears actually also give us a way to think about how to attack the disease. So you could go very upstream and treat the insulin resistance using GLP-1 receptor agonists, which work outside the liver. There are PPARs. Then there are things that target the liver. There are thyroxine beta receptors, de novo lipogenesis inhibitors, and there's a whole slew of new targets that are now being looked at. And of course, FGF21s are a really important part of this story as well. And we'll get into this sort of in a little bit more detail. So having put this broad framework of why it is important, why it is important to why the disease is important, why it is important to capture fibrosis as a marker of progression, and what are the therapies and how we think about those from a mechanistic point of view. Let's talk a little bit about, what therapies are currently available and where do they all fit in. So I would like to pose maybe the first question to Dr. Anstey here. So Quentin, tell us a little bit about, the current and the emerging treatments for moderate and advanced fibrosis.
Yeah, absolutely, Arun. Now, this is a bit stressful because I've got 60 seconds, haven't I? So we'll have to bear with me on this one. But we've got to build up on exactly what you described. We start off with the pathophysiology, and we might be taking drugs that target insulin resistance or lipotoxicity and oxidative stress or inflammation or cell death or fibrogenesis. So they're broadly in 3 buckets, aren't they? There are the metabolic targets, the anti-inflammatory targets, and the anti-fibrotic targets. And what's really interesting here is that under each of those, we've had some very promising signals and a couple of false starts along the way. So we started thinking about FXR agonists a few years ago. There was some efficacy there, but in the end, things didn't pan out. But what we do have under this bucket are a number of really exciting and promising targets and agents that are in phase 3 clinical trials at the moment. So we have the THR beta agonists like resmetirom, which of course has been licensed by the FDA and the European Medicines Agency. We have the GLP-1 receptor agonists like semaglutide. Again, that's been licensed by the FDA under Subpart H. Then we also have FGF21 agents that are still in phase 3 trials with some very exciting data coming through on those. And those of you at this meeting will have seen data suggesting the ability to reverse cirrhosis. And finally, the pan-PPAR agonists, which we're looking forward to seeing the results of their trials probably late on next year. Beyond that, we've looked at a range of anti-inflammatory agents and also some specific anti-fibrotic targets. But those on the right-hand side don't seem to have panned out quite as well thus far. But what we've got here is a really good mixture of potential targets that we can take forward.
So, Quentin, then, can you do sort of, we know that the thyroxine beta resmetirom is an approved therapy, and then we have GLP-1 receptor agonists that are approved. So those are things that we have available to us in everyday practice. So can you do a little deep dive for us? And of course, I want you to do a deep dive, but we got a 60-second clock over here.
Oh, well, this is Mina's going to.
Oh, it is you. Okay.
Yes.
So, all right. So let's put Mina on the spot. Okay.
That was more stressful then,
No. Yeah, as everyone knows, resmetirom, a thyroid hormone beta agonist, has now been approved. It's been, since March of 2024. And it's important to note that thyroid hormone receptors come in 2 flavors, alpha and beta. Alpha are highly expressed on the bone and the heart, and when you think of thyrotoxicosis, tachycardia, bone loss, that's really an alpha effect. Thyroid hormone beta receptors are expressed in the liver, the kidney, and in brown adipose tissue. Now, in the liver, the beta is expressed overwhelmingly higher than the alpha. And so resmetirom is a thyroid hormone receptor beta agonist, acts like a thyroid mimetic. It enters the hepatocyte, and one of the key things it does is it promotes the burning of fat, so increases mitochondrial capacity to burn the triglycerides, so fatty acid oxidation. And so over time, when we have excess fat accumulation, by revving up the mitochondria by two ways. One, it promotes biogenesis of mitochondria, so the replenishment of new mitochondria, and also mitochondria that are a little bit tired because they've been working so hard and it's time for them to retire. It kind of clears those. The other thing that it does is increases the expression of LDL receptors on the liver. So when we think about the other factors that we need to think about, resmetirom also decreases LDL. Whether that translates into a cardiovascular benefit, I think will be an exciting thing to see in the near future.
But I think pretty much you'd agree that based on what we know about LDL cholesterol, that if you do lower the LDL cholesterol, virtually across every mechanism of action that's been you studied before, that it does translate into cardiovascular benefits. So looking very good.
Yeah, and I think it also decreases Lp(a), which may be even a better marker for reduction in cardiovascular
So
risk.
can you walk us through the data for the efficacy and safety as well?
Sure. So the FDA approval was based on the Maestro-NASH study. This was the registrational study with a 52-week biopsy. Patients were either on 100 of resmetirom, 80, or placebo. And if you look at resolution of MASH with no worsening of fibrosis, you see 30% in the 100 milligram group compared to 10% in placebo. And then liver fibrosis improvement by greater than one stage with no worsening of steatohepatitis, 26% compared to 14%. Diarrhea and nausea are the most common side effects. They tend to occur early, and they're usually gone by 12 weeks.
So, okay, let's switch gears then. Let's talk about GLP-1 receptor. And then, Quentin, maybe I can come to you. And can you walk us through the same story, but with GLP-1s?
Absolutely. So here we're talking about the incretin hormone agonists, aren't we? So the one we're probably most familiar with are the pure GLP-1 receptor agonists, like semaglutide. That acts predominantly in two places. First of all, in the brain, so it acts centrally to reduce appetite, and therefore it helps people lose weight. And secondly, in the GI tract, where it slows up gastric emptying, and again, that feeds through to reduction in food intake and again helps people lose weight. So those are really important features. In addition to that, the GLP-1 agonists also stimulate insulin secretion, and so it's helping directly with that glucose balance in the body. So that's the standard GLP-1 monotherapy. But what we're also seeing are dual and indeed triple agonists. A great example of that would be combining it with a glucagon receptor agonist. So that's something like survodutide, for example, which brings in some additional effects within the liver itself, where you actually have increased mitochondrial turnover and essentially greater fatty acid oxidation, so that burning of the fat as well. Or we could be looking at GIP-1 receptors, where here that's like tirzepatide, and you again get some additional effects that can also improve the metabolic milieu.
So again, tell us from a patient's perspective, all the mechanisms are great for us academics, but patients want to know whether their liver's going to get better or not.
Let's look at the data.
Yeah.
Absolutely. So these are the data from the phase 3 ESSENCE study that was actually presented at this meeting a year ago. Again, there's been FDA approval for moderate to advanced fibrosis for semaglutide as part of a holistic approach, because obviously lifestyle change has to underpin that. There are two endpoints we always look at in clinical trials. The first of those is resolution of steatohepatitis with no worsening of fibrosis. And you can see there that patients who were treated with semaglutide, 62% of them met that endpoint, as opposed to about 34% of individuals in the placebo arm. So we can do the maths, but it's somewhere around about 28% difference there. And then for the fibrosis endpoint, 36% of individuals who were on treatment had at least a one-stage improvement in fibrosis without worsening of steatohepatitis versus 22% on the placebo arm. So around about 14% improvement over placebo. This is great. Both of these statistically significant, meaningful changes, not only in the liver itself, also with weight loss, also with some improvements in HbA1c. There were, of course, some side effects, and GI side effects were the most common in the semaglutide group.
I think for both thyroxine beta receptors and for these GLP-1 agonists, so we're used to hepatitis C treatment where we have 99% cure rates. So some people would say, wow, these are not that exciting. It's getting started. But maybe the way to think about this is really that it's not just the regression. Because if you're at F2 and you regress to F1, you're not getting outcomes at F2. It is, in the end, reduced progression to cirrhosis, right? And these are all ongoing studies. I think that's another thing that's worth pointing out, that eventually everything has to be, you have to connect the dots to progression to clinical outcomes, progression to cirrhosis. But this is very exciting that you not only have regression, there's also another group of people whose disease is being stabilized. And I think in the long term, we'll find out.
Absolutely, and I think, 1 year is a high bar to see fibrosis regression. I mean, it took 20 years to get there, and now we've kind of put a very high standard that we expect fibrosis regression at 52, 72 weeks. So I think it's yes, but let's see what happens. And again, progression to cirrhosis is the most important thing.
I think this is a really important point. And, you said this about viral hepatitis right at the start. But if we look back to the 90s, we weren't seeing SVR rates in the order we see now. We've got to remember, we're at an early phase in the drug development here.
Absolutely. Absolutely. And I think these are important considerations, to keep in the back of our mind, that even after viral hepatitis with phenomenal virologic responses, it takes 2 years plus to seeing the needle shift on fibrosis. Now in this particular disease state, within 1 to 1.5 years, we can shift the needle on fibrosis, and I think more to come. So again, this brings us back to another question. So, we talked a little bit about GLP. Another drug that is approved, at least in the US, for obesity and diabetes is tirzepatide, which is a GLP-1 GIP co-agonist. So essentially, Quentin, can you tell us sort of how you think about these two different drugs,
Yeah, absolutely. So here we're looking at phase 2 trial data, so much smaller cohorts, and it's worth remembering that. But again, we're looking at those same 2 regulatory endpoints. First of all, in red for the tirzepatide and underneath for survodutide. And what we're seeing with both of these is substantial delta, substantial difference between placebo and the treatment arms. So if you look at the highest dose of tirzepatide there, 10% placebo response rate, 62% for tirzepatide for resolution of MASH. If you look over on the fibrosis side for that one, quite a high placebo response rate, 30% in that study, and somewhere between 51 and 55% fibrosis improvement rate. So still a delta of over 20% there. Then when we look down at survodutide, we can see very much a similar picture. So a good difference in magnitude of effect on active treatment compared with the placebo response. Once again, generally well tolerated, and like so many of these agents, we see some GI side effects. But I think we have to appreciate that that is part of the mechanism of action, and so really is a marker of target engagement rather than anything else. As you say, I think these are very encouraging data. We need to wait and see the phase 3 trials read out to really get an understanding of it. But there's an awful lot, if I was a patient today, an awful lot to be optimistic about in this space with all these agents coming through.
And the ongoing phase 3 trials for both of these molecules.
Absolutely.
Currently. Okay. So, of course, there's another molecule that's in development. We haven't talked about it because it's not available for routine practice. But it is in phase 3, has completed enrollment.
Yeah.
So we're now waiting for the last patient to have their last visit, so that we'll have the readout in a year. a little over a year from now, hopefully. So these are the people. This is lanifibranor.
Yeah.
So Meena, can you walk us through sort of why PPARs, what's going on with lanifibranor?
Sure. So, lanifibranor is a pan-PPAR, which means it has alpha, delta, and gamma. And so the alpha component helps to target the steatotic hepatocyte. The delta component kind of squelches inflammation, targets infiltrating macrophages. And then the gamma has the more stellate cell specific or more of the anti-fibrotic effect. And the studies that have been shown here, this is the phase 2b study that Arun alluded to. So the primary endpoint here was reduction in the SAF activity score, which is similar to thinking about the NAFLD activity score, and no worsening of fibrosis. You can see that the 1,200 milligram group had 49% compared to 27% in placebo. And then when you look at the improvement of fibrosis and no worsening of MASH, you can see 42% in the 1,200 milligram group compared to placebo. And then resolution of MASH and no worsening of fibrosis, 45% compared to 19%. In this study, there was also very good cardiometabolic improvements, reductions in LDL, increases in HDL, improvements in hemoglobin A1C control, AST, ALT reductions, ProC3 reductions. The one kind of Achilles heel for this drug is a little bit of weight gain that you get. So with the gamma part of it, you also get the weight gain. And so in the trial, patients gained about 2.5 kilograms. So, certainly not a large amount, but when you're drilling into patients, lose weight, lose weight, lose weight, it's a kind of a tough sell when you say, well, you're going to gain a little bit on this one. That being said, keep in mind it's really fat redistribution. And so there is loss of visceral adipose fat, which is the most important fat that drives this disease. And it's kind of moving out to the periphery. So it is a redistribution of the fat, and that's important. There is a little bit of, you have to be careful if the patient has a history of heart failure. But otherwise, I think it's going to be a good option, very good option for lean MASLD. But certainly we wait to see the phase 3 studies.
And then what about the FGF21s?
I think we'd all agree this is probably the most exciting agent class that we've seen. FGF21s have pleiotropic effects on various organs. Like the GLP-1s, there is this decreased desire to eat sweet, even an alcohol reduction in preference in the liver. There's a decrease in de novo lipogenesis and decrease in lipotoxicity. There are some kidney protective effects. And then in the same as in the cardiac tissue and vasculature, decreased inflammation. Pancreas, again, increasing beta cell function, increase in insulin. And then in the adipose tissue and the muscle, which is very important, increased insulin sensitivity. In the adipose tissue, there's increased secretion of adiponectin, which actually targets stellate cells and is anti-fibrotic. So lots of mechanisms by which these molecules will be exciting. Part of the problem is that the endogenous hormone, it has a half-life of only 2 hours. So every drug that you see is because there's been some modification in order to extend the half-life. So we have the efexofurmin there, which is weekly. So this is phase 2 study where the endpoint is looking at that one-stage improvement in fibrosis without worsening of MASH. So you have Harmony and Symmetry. Harmony was in the pre-cirrhotic population, so that's F2, F3 fibrosis. And you can see a 75%, be in mind 96 weeks, 75% improvement in fibrosis compared to 24% in placebo. And then the Symmetry, which is now compensated cirrhosis, and I think we could discuss this, but this is the most exciting thing because many have hit the cirrhosis graveyard, and so it's nice to see a pharmacologic therapy that is showing some promise on cirrhosis reversal. And there they have 39% kind of went from F4 to F3 versus 15% in placebo. And then pegozafermin, now you have this 2-week administration, and there in pre-cirrhotic MASH, you see 27% versus 7% in placebo. I think just to point out that there was a small reduction in bone mineral density at week 96 in the Harmony trial. And I think that's something that everybody's watching a little bit carefully, any potential impact on bone. And certainly patients who have osteoporosis are excluded from the clinical trials.
Yeah. I think a couple of things that are really remarkable to me when I look at these data. One, that in the pre-cirrhotic patients, that by the time you get to week 96, 3 out of 4 patients actually had regression of their fibrosis. I think that's pretty incredible. The second thing that was not on this slide, but maybe you can speak to it also, is that in that particular study, they also had an early time point.
Yeah.
And it didn't look quite as dramatic at that point. So it goes to show that some people will regress their fibrosis within that first 6 to 12 month time frame, but there are also people who will show fibrosis benefit within that 1 to 2 year time frame. So a common conception is that whatever you see at 12 months is what you see is what you get. But I think for a lot of these where you're treating the root cause or you have pleiotropic effects, that with continued use, you will start seeing subpopulations who are able to mobilize some people can mobilize their scar tissue faster, and some people, it takes longer to mobilize the scar tissue. What do you think?
Well, I think just like there's fast progressors, there'll be fast regressors. You know, we don't know that the mechanisms that dictate fibrosis resolution are the same as, and there could be genetic determinants of regression, just like there's genetic determinants of progression.
Yeah, I mean, I think it's really interesting. I think there's another function we need to remember here, which is the way the histological scoring works. So if you think about what it takes for cirrhosis from F4 to go to F3, we always imagine that the way it would happen is that progression will happen in reverse precisely. But actually, those bands of fibrosis probably narrow for a while before they break. And so that just takes a little bit longer. So I think there's a biological aspect to it. There's also a feature of how we assess fibrosis in a cirrhotic patient. But clearly, you've got to keep going with these agents. As Mina said, it takes 20-odd years to get to this. You've got to give it a chance to come back the other way.
Yeah, I think what is particularly exciting is that in a disease that takes 15 to 20 years to progress to cirrhosis, it's okay to take 2 years to get a 75, 80, 90% fibrosis regression. And we're really looking forward to seeing when they can combine the GLP and the FGF21s, you know, and see where we land. And I'm very hopeful that that'll land us into the 90% plus. Then we can start comparing our field with Hep C, right?
That would be good.
A little competition's always good. Okay.
Sorry.
So let's sort of talk about, we've already started talking about where the field sits right now, but I'm just breaking it down into some of the big areas. So we pointed out that these are ongoing trials. We don't have the long term. So are there elements over here that for the practicing clinician that they should keep in the mind, at the back of their mind, particularly with the approved drugs that are available to them that they are able to use on an ongoing basis? So maybe I can start with you, Quentin, this time.
Yeah, no, absolutely. I think there's a lot to be considering. These are, as you rightly say, drugs that have been approved under Subpart H. Some of them are licensed for other indications already, and so are available there. But we always need to be live for the fact that they remain under investigation. I think we need to consider the patient holistically, and we need to consider how each different drug fits into that holistic picture. So the balance of cardiovascular risk, the balance of liver-related risk, and I think we need to weigh all of that up when we're selecting a particular agent for a particular individual. It's great, certainly over here in the United States, you've got 2 to pick. For me in the UK, as of yet, I haven't even got 1, so I'm looking forward to that.
So you'll be well prepared by the time you get them.
Well, I'll know after today, I'll know what to do. Yeah, absolutely.
Okay, all right. So Mina, you have all these drugs available to you. All right, so I'm going to put you on the hot seat here.
Sure.
So we have which one do you start with? Who do you start with? How do you decide which one? When do you think a combination may be useful?
Yeah.
Let's just start the conversation with the drugs we already have approved
Right.
that all of us in the US
Have access to.
have access to.
Yeah.
Let's start that conversation.
Yeah, I mean, I think taking that holistic approach, right, you need to think about all of the comorbidities that that patient has. And so if the patient is living with obesity, has, maybe elevated hemoglobin A1C, not fully optimized, then I think you might start with a GLP-1 receptor agonist with the hopes that you can address all of those things simultaneously. That's when you're prescribing it for the liver, but you're getting those other benefits. On the other hand, a lot of people don't tolerate GLP-1s, a lot of people don't want to take an injection, and I think in that case, you might, they don't have those other comorbid conditions that are uncontrolled, then you might start more with a resmetirom and see where you get there. I think that in patients who have really advanced disease, like they're teetering on cirrhosis, like they're just kissing cirrhosis, right? Like these are the 18 kPAs, 19 kPAs. So you might start one, whichever you think is the first one to start, and then you want to see maybe after 6 months to a year, how far have I gotten with that therapy? So your question is sequential. For those people who are really teetering on the edge of cirrhosis, because such badness happens once you hit that point. If I want to add something on, that's the patient where if I'm not quite getting that kPa down, that liver stiffness down, I might add a second therapy. Because the side effect profile of these are very similar, I don't usually start at the same time because they all cause nausea, so I won't know even which is causing what. And so I'd rather start with one, whichever fits best for that patient, shared decision making, and then add on a second.
Yeah, I think I'd use a very similar approach as well. But the more common situation I face is that the primary care physician starts the patient on a GLP-1 and patient just happens to have elevated liver enzyme. This is a very practical, real life situation. They call and they say, okay, and go see a hepatologist. And it takes 6 weeks to get an appointment. So the patient comes to see me, they've been on GLP-1 for 6 weeks for their obesity or diabetes or both. And their weight is beginning to come down. In that kind of situation, I'm sure you see the same, right?
Yeah.
So how do you sort of assess those patients, and how do you decide when you may want to consider, and what tests do you use? Because I'm trying to create a segue to now starting to pivot towards how we use our NITs,
So if a patient's coming to me, right, they're already an at-risk patient. So I want to use tests that have a higher positive predictive value because they're selected, right? So now it's an enriched patient population. So in that patient that you suggested, I'd probably, because we have access to VCT in our office, I'd start with that. And if I'm confident that the test is a good one, that the IQR is reasonable and I'm happy with the images, then I might use that as a first assessment. If I'm not happy, because I think that with their obesity I'm not getting good readings, then I might want another NIT, in which case we have access to MR elastography, which I might do that, or I might send an ELF test. So I have options for what that additional test might be. But in that scenario where the medicine has already been started, I'm going to see what I get from that medicine first before I think about adding on some therapy, because they need to get to the maximal dose of 2.4 really to get to that sweet, level.
So can I ask you a question? Because I think one of the things we've been thinking about a lot in terms of the National Health Service in the UK is preparing for the day when we have some of these drugs available. We've talked about what we might initiate. What's your thinking on discontinuation of agents if you're not seeing efficacy after, say, 2 years or 1 year? When would you start thinking about that, and would you treat all agents the same or maybe some agents differently?
So I think I wouldn't treat all agents the same because, so let's take the GLP-1s for an example. So if a patient's, you started it for a liver indication, but they also had other comorbidities. So you've started it, they haven't had the fibrosis regression you want, but they've had the weight loss and they've had improvement in glycemic parameters. So now I might continue it for another reason and now bring in a liver-targeted therapy. I wouldn't stop it. That's different for a resmetirom, where if you're on it for 2-3 years and you're not seeing any efficacy, what other benefits other than maybe LDL reduction am I getting? In that case, you might say they're not a responder to this particular drug and I might need to shift gears.
So, this morning from the Essence trial, Phil presented our data and showed that even with less than 5% weight loss, there was significantly increased MASH resolution, there was a fibrosis benefit, there were metabolic benefits, et cetera. And we know from the old obesity literature that even a very small amount of weight loss is associated with improved insulin resistance, everything else.
Yeah.
So the important takeaway is many of my colleagues think if a patient does not lose weight, they are by definition a non-responder from a liver perspective. And so the data this morning suggests that's not true, and that before you sign off a patient and say you're a non-responder, don't take this drug anymore, it behooves us to sort of assess the fibrosis status in the liver. What's your take, and then maybe we'll hear from you, Quentin, on these data that was just presented this morning?
Yeah, I wasn't there, but I mean, I can understand the concept that weight loss, any weight loss is going to have some beneficial effect. So that's a situation like that where I said, if you're getting benefit in other parameters, glycemic control, other things, then you would continue that therapy.
Well, you may even get liver benefit
But
with
the
almost
point is you
minimal weight loss.
Yeah.
So I think that's an important practical consideration, that don't stop without checking the liver out.
No, and it also speaks to, I think, to that holistic view, doesn't
Yeah.
it? Where, because of the cardiometabolic benefits, and there may still be some undefined hepatic benefit from what you're saying, Arun. I think that sounds like a really interesting situation to be in.
I think it's going to be important for payers to see that too, because they may then say you didn't get X amount of weight loss, and we're not going to approve
I think we'll have
it
to
any
educate
further.
the payers
So
about
that data is going to be really important.
Yeah. So moving on, let's just talk now a little bit about sort of how we approach fibrosis, and then Quentin, get us started.
Absolutely. So, I mean, we're talking about here really how we're going to find patients with significant disease. And there are a range of different biomarkers we can have in our armory. Some of them are what I call the wet biomarkers, so they're blood-based biomarkers. Others are the dry biomarkers, that's the imaging biomarkers. And for the majority of this conversation, we're going to focus on biomarkers that detect fibrosis. And there's a reason for that. The biomarkers that detect fibrosis, we know that it's fibrosis that predicts long-term outcomes. So we really want to be good at identifying individuals who have clinically significant or advanced fibrosis. So clinically significant in histological terms, we'd call that F2, F3. Advanced fibrosis, we'd be talking about F3 and beyond, and obviously cirrhosis, F4. So that's one key thing we need to think about. The other one is this idea of identifying at-risk MASH, patients with active inflammation and starting their journey to scarring, where they've got at least that clinically significant fibrosis, maybe a little bit more. Because we've been able, oh, that was good. The lights go out, or was that just my retina detaching? Okay. So because the fibrosis biomarkers we can borrow from other disease states, there's a lot more information there that we can draw on and a lot of prior knowledge. When we start off with the guidelines, and this is possibly one of the most daunting pictures I've ever seen in my life, but actually it's a very straightforward two-step guideline that's been generated here. We need to start off with a simple score, something that's relatively inexpensive, something that helps us to rule out advanced fibrosis and reassure our patients that right now they don't have significant disease, and it needs to be cost-effective in that setting. So the first step here is to assess risk. Does this individual have cardiometabolic risk factors? The second thing to say is, right, if they do, I'm going to use a simple score like the FIB-4 score, and I'll talk a little bit more about the FIB-4 score, but it's based on 4 readily available parameters: an individual's age, their platelet count, their ALT level, and their AST level. Let's use that as our first triaging point. If we find an individual who has a FIB-4 of less than 1.3, we can give some lifestyle advice, we can be relatively confident that they don't have significant fibrosis, we can come back and retest them in a year or two. If we find the FIB4 is greater than 1.3, then we need to move from the high negative predictive value to starting to rule in disease. And that's where we come to a second-line test, like FibroScan, or like a test like ELF, both of which are recommended in the guidelines. And that helps us to guide our onward referral from primary care to specialist care. What is FIB4? Well, I've already sort of mentioned what goes into the recipe, but the nice thing about it is it really red, amber, green. This is a simple traffic light system that I think we can all use. It can be built into your electronic care records. If the value is less than 1.3, we can rule out significant disease. In fact, in individuals over the age of 65, we can probably say that if the value is less than 2, we can rule out significant disease. The intermediate zone is there in the middle. Those are the individuals we need to keep a very close eye on, and we start to move on to a second-line test. And then there's the rule-in, the high positive predictive value threshold. But I don't know what the others do. I tend to focus on that low threshold, the 1.3 value, and I use that as my gating tool to move on to a second-line test. The nice thing about FIB4 is that it works to tell you how much disease you've got now. But this study, and I'll spend a moment or two on this one, tells you that FIB4 can also predict the future. So this was a study we did in the UK in a very large primary care data set. So this is unselected patients seeing general practitioners all across the United Kingdom. What we did was we measured their FIB4 values, and then we looked forward up to 10 years of follow-up in this study. And we looked to see what cardiovascular events or what liver-related events or what all-cause mortality occurred. What you can see is that if you're in the low-risk category, you're actually very unlikely to experience either a liver-related or a cardiovascular-related event. If you're in the intermediate, that risk goes up, and by the time you're into the high-risk category, the risk of particularly liver-related events, but also other forms of events, goes up with it. So here we have a tool that acts as a diagnostic. What have you got today? It acts as a prognostic. This is a really important thing. It's a way to focus our attention on the individuals most likely to come to harm. And I've alluded to this before, because it's cheap as chips, we can repeat it again 12 months later or 24 months later. And with that additional information, looking at the change in FIB4 over that period of time, we can refine our prognostication. So, for example, if you're already in the high-risk category and your FIB4 goes up by just 1 unit, your hazard ratio goes up to 24. Similarly, if you're in the high-risk category and the next time it's tested, it's dropped by 1 unit, your hazard ratio drops to 10.9. So this is a phenomenal tool at very low cost to stratify and monitor patients and refine our diagnostic pathways. And I think that's a really important message for us.
So if I could add another thing over here to this is that, if you have 2 points in time and you're measuring change in the biomarker for fibrosis, and you're looking at clinical outcomes during that time frame, you sort of know the answer already when you're checking the second. So as a practicing clinician, that didn't help me so much, right? I'm just, so what I want to know is if I did the test a year ago and I'm repeating the test today, when no events have occurred, what can I say about that change and the likelihood of an event occurring from today to the next into the future, looking into the crystal ball?
So we specifically gated this analysis so that it wasn't, oh, look, I did the FIB4 and your liver decompensated 3 weeks later. Gosh, wasn't that good? We deliberately gated it so that we were looking into the future here, even after the second measure.
I think that's a really important
I should have said that. You're absolutely right. It is an important part of the story.
You owe me again.
Yeah, no. I'll buy you a beer later.
We are not a meta-ALD session. Anyway, but that's a different conversation.
Only one.
Stay focused. Stay focused. See, alcohol does bad things to you. That's the message in the liver meeting.
Yeah, there you go. It affects your FIB4
and
too.
Here we go.
There we go. So tell us.
FIB4, of course, is not perfect. Far from it. I would not wish to say it was. But there are certain things we need to be aware of with it. First of all, and I've alluded to one of them, as we get older, age is part of the FIB4, so we can overcall, particularly in individuals over the age of 65. So we need to build that into that thinking. Binge alcohol consumption or very high levels of alcohol consumption that push up the AST level can also mean that the FIB4 score overcalls, and I think that's important.
And drop your platelet counts.
And drop your platelet counts. And that, combined with some other causes of platelet count dropping, can all be important. So we need to factor those things into our thinking. It doesn't work for everybody. You have to assess it and apply it on an individual level.
Yeah. One, interesting.
Yeah.
Are there folks from Asia here? Can I see a show of hands? How many people from Asia, South Asia maybe in the room? Not a lot.
1, 2.
But certainly in the subcontinent, there is this syndrome where the platelets are a little sticky. So on a regular automated counter, it looks like you have thrombocytopenia.
Yeah.
And then if everything else looks good, you really should think that they have that sticky platelet syndrome and get a manual count.
Yeah.
Otherwise, you could again fall into the FIB4 trap.
It's important. And most of the data that's looked at FIB4 hasn't been done in those populations. So that's a really important caveat, actually. A great piece of research for somebody in that area to do.
Yeah, exactly.
So as Quentin shared this slide earlier, so FIB4, kind of your first line of defense, it's cheap as chips. Is that what you said?
That's what we said, cheap as chips.
I like that, cheap as chips. So low FIB4, less than 1.3, you're low risk, you stay in primary care, you optimize other conditions, and you repeat that FIB4 annually or every 2 years because you want to see if that changes. Now, if the FIB4 is greater than 1.3, as Quentin said, now you're moving over into needing something else. And what is most commonly recommended are VCT and ELF. And when you think about VCTE, these are kind of the cutoff. So all of the studies, the resmetirom, GLP-1, they're really focusing on patients with non-cirrhotic MASH consistent with F2 and F3. Why F2? Because that's when liver-related outcomes start to go up. So by the time you have F2 fibrosis, you have a 10-fold increased risk of liver-related outcomes that increases to 17-fold at F3 fibrosis. So the goal is to identify people at that F2 threshold to engage them in care, whether that be obviously lifestyle intervention, but also potential pharmacologic therapies. So for VCT, this kind of 8 kPa is that threshold where you're now at risk of having F2 or higher fibrosis. And the CAP score measures the amount of steatosis, and here they're recommending 275. There's different numbers there, but the point is you want to see if there is steatosis, and the CAP on FibroScan can give you that information. Now, not everybody has access to VCTE, and so there is a enhanced liver fibrosis test, or ELF test, which is available in the United States and available in the UK. Yeah, available in the UK as well. That's actually gives you a view kind of more on what's happening biologically in the liver. So it's made up of 3 components, and it's when the stellate cells, which are the cells that create that fibrosis in response to injury, start producing collagen, they're initially single fibrin collagen bundles, but then the N-terminal peptide of that has to be cleaved for it to form the classic triple helical collagen bundle. And so this is actually measuring the P3NP, which is that cleavage product. And hyaluronic acid is a glycoprotein that's necessary for that extracellular matrix deposition. So in the ELF test, you're looking at hyaluronic acid and P3NP. On the other hand, we talked about regression, and macrophages are constantly trying to resorb that collagen through the secretion of matrix metalloproteinases. But there are inhibitors of those matrix metalloproteinases, and TIMP1 is a classic one, so it inhibits that kind of regression. So this score includes these biologic markers, and while currently it's FDA approved as a prognostic, where an ELF score greater than 9.8 predicts the progression to cirrhosis, and an ELF score greater than 11.3 predicts a liver decompensating event. I think Arun will share with us in a moment a little bit on data about kind of using it more for staging and diagnostic as opposed to just prognostic. But just finishing up on the predictions, you can see if your ELF is less than 9.8, you have a 0.2% chance of having a liver-related endpoint at 5 years and only 0.5% after 10 years. As your ELF increases to 9.8, 11.3, you see that those liver-related outcomes increase. And once you have an ELF greater than 11.3, that's associated with a really significant risk of having a liver-related event over the next 10 years. So I think this is what, Arun, you presented at this meeting a little bit on kind of rethinking ELF.
Sure. So I think basically this is a little deeper dive on sort of the prognostic utility of the ELF score. And this was a study that was based on all of the Gilead trials that were done for NASH. Unfortunately, most of them were sort of negatives, but that allowed us to pull the data. So it was 2,000 plus, almost close to 3,000 patients. But what you see is basically that below the classic cutoffs of 8.2, there's virtually no outcomes. But really to align with the intermediate risk, if you draw the line at 9, the likelihood of clinical outcomes below 9 is extremely, extremely low. Between 9, then it starts rising. And then, of course, above 11.3, it is elevated, but the highest is above 12.8. So there are substrata within the ELF range that give us more granular, you were talking about having more granular detail, that give us more granular understanding of risk. The other thing is, so that's your baseline risk, right? But then also change in risk. So one of the things we want to do is, if you see a patient and you say, okay, we're not quite ready to put you on a drug for your NASH, but then you see them a year later, how much of a change is a meaningful change? And so I think it also shows that, one, the same degree of change, the higher your baseline level, it has a magnifying amplification factor for prognosis. So the way my thinking has evolved personally, and I would love to get your take on this, is that the original 1.3 came when there were no drugs approved. And so we were using that as a way to look for people who had advanced fibrosis or cirrhosis, because in that population, we would start doing HCC surveillance and other kind of things. So it would lead to clinical decision-making of some sort. Now we're saying we're going to start treatment earlier at F2. And I think that was never designed. That F3 was designed to capture advanced fibrosis. So maybe that first gating step needs to be rethought. That's one. Number two is that we can either think of it in terms of fibrosis stage, which is the classical way, and the approval and the studies that have been done were for F2s and F3s. But if you think about risk stratification from a patient-centric point of view, of things that the patient cares for, then there's this data that the liver stiffness below 10, you have very few outcomes, and it's really your outcome risk starts increasing when your liver stiffness rises above 10. So the guidelines say liver stiffness 8, and there's some conversation about the ELF of 7, but 7 may be too low, maybe 9 is the appropriate one. Those would be so we align the cutoffs in a way that makes sense, aligning them with the fibrosis stage, but more importantly, trying to align also with the clinical risk to the patient. And so maybe those 8 could be 10, and the question then also is, what would you do with somebody who falls in there? Because with VCTE, we know there's variability, So if you see a result of 10, if you say 30% variability on either side, truth could lie anywhere between 7 and 13. So Quentin, you first.
Yeah, no, I mean,
How has your thinking evolved over
So,
these last few years?
I think you're making a really important point here. We're actually, in terms of our understanding of non-invasive tests, we are in a transitional phase at the moment. Part of the time, we still tie them back to histology. Even today, we've been talking about F1, 2, 3, 4, when we've been talking about how non-invasives change. But undoubtedly, the direction of travel with these, and it's exactly what you're alluding to, is we need to start using these tests as tools in their own right that carry with them at different thresholds a prognostic risk, whether it's 20% risk, 30% risk at 1 year, at 5 years, at 10 years. Just like we would with the Framingham Heart Score, just like we would with the FRAC score for hip fractures and osteoporosis. It's a total change in our thinking. I think we're starting it, and I think these data are a really important step along that way.
Yeah, I agree. I mean, I think the only reason we even talk about F2, F3 is because our specialty came out of pathology.
Yeah.
I mean, otherwise we'd never even be. So now I think stiffness-associated risk stratification is one, is an approach. As the stiffness increases, the outcomes are worse. And on the flip side, we have 2 studies that show if you drop that down, they improve through either VCT, as you point out, less than 10, and then the Agile 3 score, which has a VCTE component in there. If you can flatten that out, you're going to have improved outcomes.
Okay, so I have a question for you. So we've talked about fibrosis staging. We talked about aligning the cutoffs, whether it's a ELF cutoff or a FIB4 or a VCT cutoff. So FIB4, we may need to go dial it down. VCT, maybe dial it up slightly from 8 to 10. ELF, maybe dial it up from 7 point something to about 9 as our starting, as a lower gate to decide who gets on therapy. But then there's some data now on how do we then follow the patients with the 2 drugs that have now been approved. And so I'm just leading up to this. So we have a slide over here on PDFF. And do you use it, A? And how do you use it?
I use MRI elastography when I am not sure about my other NITs, so it is my tiebreaker, and MRI PDFF comes with that. So naturally, I look at the MRI PDFF. When you're not, MRI PDFF allows you to get that 5% steatosis. So obviously, it's helpful if you're not sure the person even has MASLD or MASH, and you want to be able to determine whether they have significant fibrosis, because FibroScan can only get you down to 11%. Ultrasound, you're talking 20% steatosis. So this is the most sensitive if you are concerned about whether or not you have even MASH.
So I was actually alluding to something a little bit different. So once you start treatment,
Yeah. Do I use
as a
MASH
treatment,
no.
as a response biomarker?
No. I don't get baseline MRI PDFF as I'm starting treatment, and therefore I don't look at 30% reduction as a surrogate marker for improvement.
So that's been published that 30% reduction
Yes,
in PDFF
yes,
is a good biomarker.
But it's not, I don't know how practical it is.
Yeah, so then that's again the issue of access and cost and all of those things come into play. And then again, aligning with MR, because
so
clearly MR elastography is better than FibroScan elastography in terms of accuracy and repeatability, reproducibility. But but the cutoffs are a little bit different, right?
A little bit
Can
different,
you talk to us about that?
Sure. So when you talk about MRE, the scale is different, and a kind of cutoff of 3.64 is kind of where you have more that stage 2, stage 3 fibrosis. Greater than 5 kPa on an MRE is consistent with cirrhosis. So really, that's kind of the range that you're talking about of pre-cirrhotic MASH. Okay, I think we're going to do some cases, right?
Yeah.
All right, case 1. All right, we have a 50, I think now you might need to participate here. 58-year-old male with type 2 diabetes, well controlled on metformin and a DPP-4 agent, BMI of 24, has some dyslipidemia, and there's AST is 47, ALT is 35, and the platelet count is 160. And this individual's FIB4 is 2.9. So based on that 2.9, right, we know that they're not in the low risk, don't worry about it. They're actually on the higher risk side of things, so greater than 2.67. So this patient would be recommended to then come to a hepatologist, one of us. And now we have to do a secondary testing. And so depending on what you have available to you, either one is an option. You have ELF, and in this case, the patient's ELF was 10, and the VCTE was 12.5. So in both cases, this is suggestive of advanced fibrosis. The limitations of VCTE are when you have a really high BMI, sometimes it's difficult to get the VCTE, and that's where ELF can be helpful if you don't have access to VCTE and if there's other contraindications. So what ELF cut, this is a polling question, what ELF cut points determine disease progression? No, maybe it's not. Okay, so ELF cut points, so as we've said a few times, greater than 9.8 indicates a high risk for progression to cirrhosis. 10.5 is kind of where you're likely to have cirrhosis, and then F3 kind of rules in cirrhosis and predicts events. So what treatment would you recommend for this patient? This is a polling question, so I think you have to, is there music or, I don't know.
We're going to get a drum roll, music.
Okay.
Oh, that's better.
Tabulating.
We've had some questions come in. Okay, here we go.
Okay, yeah, resmetirom. This patient would be a good candidate for resmetirom. They're lean, mean, and they have the advanced fibrosis, and so I think that would be a perfect choice. And then to answer your question, then how do you monitor response to treatment? So this patient's KPA was what, 12.5? And so we would want, and his ELF was 10. So response to treatment at 12 weeks would be your efficacy time point. A 30% reduction in that 12.5, so probably, I don't know, 9.5, so to do the math. So getting down to 9.5 would be a slam dunk kind of response. And an ELF score of 9.5, that kind of at least a 0.5 reduction in ELF score would suggest treatment
You said
response.
12 weeks? I
said 12 months.
Oh, 12 months.
12 months.
You said 12 weeks.
Oh, okay,
Just
I meant 12 months, okay.
I'm paying attention here.
Okay, 12 months. I mean, a year is your efficacy.
Yeah. Okay.
Yeah.
So,
So the treatment management here, obviously we can start resmetirom, and I don't remember the weight of the patient, but if they were over 100 kilograms, they would get the 100 milligram dose, or 80 milligrams. No, their BMI was, so they're going to get the 80. And then you're going to, as we said, monitor for. Really, the only thing to keep in mind, I think, with resmetirom is if the patient's also on a statin, sometimes you can see this elevation in liver enzymes in the first 4 to 6 weeks of treatment, but it will come down and you just don't check it. So I tell patients, like if their primary care doctor checks their liver enzymes for whatever reason and they see that it's higher and they were recently started on resmetirom, I get those alarming calls and I say, no, it's expected, don't do anything about it, it'll come down. I don't check it. Case 2.
Okay.
Quentin,
case
over
2.
to you.
Eyes down for a full house. Okay. So, second patient, a 61-year-old lady. She's been a type 2 diabetic for 10 years. She's overweight with a body mass index of 40. She's presented actually asymptomatic, but for her annual checkup. And so we're going to go off and assess to see if there's any evidence of steatohepatitis or fibrosis present. So we've certainly identified she's got cardiometabolic risk factors. There was that diabetes, her body mass index. So we're going to move on and do our FIB4 test. If we look at the labs, we've got an AST at 85, an ALT at 60, and a platelet count of 180. Now, it's always interesting, and even before I calculate the FIB4 score, I always look at the AST and the ALT and just look at the ratio of them in my head. If AST is higher than ALT, I'm thinking that there's a high likelihood the FIB4 will turn out to be positive. I'm also thinking, am I sure that this is the right etiology? And you always got to factor that into your thinking with the patient. In this case, the patient's FIB4 score came up at 2.94, so it places her in that high-risk category. She's 61, She's not in the over 65 bracket, but even if she were, in this case, we'd be looking at the high-risk group. I go on and I perform my FibroScan, and I mean, this does happen from time to time. I don't know if everybody here sees it in their practice, but I certainly do. The FibroScan comes back reassuringly low at 6.5 kilopascals. So now I'm in a bit of a state, because I've got this patient in front of me in the room. I've got one test saying bad, I've got the other test saying good, and it really is a question of, am I an optimist or a pessimist? And I think if, again, we come back, we look at that AST to ALT ratio, the fact the AST's up, it is a worry for me, and I'm even more worried because of the cardiometabolic risks that this patient has, and therefore the likelihood in my head is that she may well be somebody with an active steatohepatitis who's at risk of progression. So what might my next step be? Well, I think I need a tiebreaker here. What I've gone and done is I've gone and calculated or ordered an ELF test. And the reason I've done that is because, of course, we know that with body mass index, as the BMI goes up, the FibroScan can be slightly less accurate. So we need to factor that into our thinking. So just like the guidelines, we've done an ELF test. I find a high-risk score at 10.2. So now I've got two tests pushing me down that high-risk category, and I'm much more comfortable with my diagnosis at that point. I'm also comfortable about it because I can look back on the FibroScan and I can think about, well, what were the reasons why it may not be accurate? The BMI would be a classic example for this, and so I can square that, and I can move on to think about therapies for this patient. So in addition to lifestyle modification, and I think this is a polling question, in addition to lifestyle modification, what single pharmacological treatment might be most beneficial for this patient? Would it be vitamin E, pioglitazone, semaglutide, or fenofibrate? Over to tabulation. Oh, what a team. Okay, I think we have a degree of concordance here, don't we?
Degree of concordance, better than the NITs. No, just bad joke, sorry. All right. I think we've talked already about sort of, the differential choices between semaglutide and resmetirom. Semaglutide, of course, brings with it established cardiovascular and renal and weight loss benefit. With resmetirom, data are primarily liver-centric, although there's reason to believe that the LDL cholesterol reduction will be beneficial, and the overall lipid profile improvement with resmetirom is also very, very encouraging. So let's see, how do we move on from here? So
other polling questions.
we have another polling question over here.
What is the ELF threshold that most commonly recommended in international guidelines for indicating a high risk of advanced fibrosis? Let's see how good we taught them. 9.8. Good.
Good.
10.5 is probably, it is advanced fibrosis, but
It
maybe
is,
more towards
technically.
cirrhosis, so that
Yes.
wouldn't be incorrect. 7.7 is very low.
Yeah.
I think, most people, our ELF is probably 7.7.
Yeah. So 7.7, I think that's one of the points we wanted to make, was in the practice guidelines it says, anything above 7 is clinically significant fibrosis. But even that
That's
may
gonna be
be
adapted,
too low.
yeah,
It's
yeah.
just,
In practicality,
so 9 is probably the threshold above which you're likely to have clinically significant fibrosis. Advanced fibrosis means bridging or cirrhosis, and 9.8 is really the optimized cutoff for that. But if you're looking for cirrhosis, I think multiple groups of people have landed at the same spot of around 10.5 for that. And 11.3 is when you have cirrhosis, but you not only for sure have cirrhosis, but you're likely to be close to outcomes. And so it's almost like enriched for, it's not 100%, it's not 1-to-1, but it's enriched for cirrhosis with portal hypertension. Do you
Yeah, I
broadly
agree, yeah.
agree with that?
Right, and that's why you see the outcomes, yeah.
Exactly, exactly. So I think some of the things that we do in our, just to make sure that we're not leaving anything behind, is most of the patients who are still being referred are not being referred because of the practice guidelines which say if you have risk factors, check a FIB4. I mean, that's what we all recommend. It's in every practice guideline. But the reality is most patients are being referred because they got abdominal imaging for some unrelated reason, and it was noted there was fat in the liver, or a person has elevated liver enzymes for which there's no obvious cause or sometimes hasn't even been looked at, and the patient gets referred. So I think it's really important when we first see the patient with MASLD, we need to first, if they come in with abnormal liver enzymes, make sure there's no other obvious reason like hepatitis C, hepatitis B, et cetera. And even if they have fat in the liver, they come in with imaging evidence of fat in the liver, they could still have hepatitis C. And frequently you have, because it's such a common condition, and if you have fat and you have elevated liver enzymes, is at least viral hepatitis. There are CDC guidelines about looking for these things. They are very specific treatments, and alcohol. I think whether you do the other stuff or not, that sort of low-hanging is just good medical practice to make sure the patient does not have viral hepatitis, and you ask some questions about alcohol. The second piece is then, you can decide how you confirm steatosis if they come in with abnormal liver enzymes. And, the CAP is actually very good for saying, yes, you have excess fat in the liver. Maybe not so great for differentiating the severity of fat, for which MRPDFF is clearly, that's the reference standard, I think, from a non-invasive perspective. And you could assess activity, and we've listed a number of things, AST, ALT, and I'll come back to it in a second. But activity refers to the metabolic stress. You remember the 4 gears we talked about? The metabolic stress, the injury, and the inflammation, that sort of activity. Fibrosis is the consequence of the activity. So we have CAP as a measure of fat, PDFF, and then there are tests like NIS2 and MASSIF. But AST, ALT, coming back to the old school, very simple AST, ALT, in many studies, turns out AST is pretty good for a fibrosis marker, more so than ALT, and ALT is pretty good as an injury marker. Yeah. So when we talked about once you start somebody on treatment, it's actually one of the questions that came in also, is where does AST, ALT come in checking response to treatment? So Meena, maybe you were talking about this earlier, so maybe
this ALT of 17, a reduction of ALT of 17 has been associated with histologic improvement, but maybe 20% from baseline. So those are the kinds of things that people are looking at for suggesting that you're having a response to treatment.
Right. And then, then basically, but the risk is driven by fibrosis, right?
Yeah.
So we don't want to lose track of the fact that activity is almost like an intermediate measure of what's driving the fibrosis. And it also gives you something that you can measure in the short term for metabolically acting drugs to make sure to see whether the drug is doing its job.
Yeah, and I think for patients, it's very reassuring, right? And I mean, it's going to be positive enforcements if they start to see their liver enzymes improving. That's, positive reinforcement to have healthy behaviors and habits to continue on that path.
Yeah, but then the eventual prognostication is done based on some measure of fibrosis, whether it is done with FIB4. Remembering, FIB4 is not directly measuring anything that's collagen related also. These are markers that frequently give you a readout for that. And let me go back one, And then really over here, you can then align these cutoffs to categorize low risk, moderately increased risk, high risk, this is sort of your cirrhosis population, and then the very high risk, which would correlate with the cirrhotic population who's getting close to an outcome. And then this allows you to think about, who would get put on a therapy. And typically it's somebody whose risk starts increasing. So while this is one way to risk stratify, to decide who goes on treatment, somewhere, and I'll put this up out there, this is what I do, and maybe you guys can react to my approach, is I'll take somebody with a liver stiffness, between 10 and 20. That would be my, or a ELF that is over 9, but less than the upper threshold for cirrhosis, because these are not approved for cirrhosis yet. And so I might use an upper cutoff of 10.5 for the ELF, and a VCT, I would prefer the more 20, as my cutoff, although the guidelines say approved for 8 to 15. So my practice is a little bit different than what the practice guidelines are, because I think there are plenty of people between 15 and 20 who are not cirrhotic. But then let me hear from you.
Yeah,
and,
absolutely.
And then hear
Yeah,
from you
I mean,
as well.
I think that, in the expert guidance so there's the green, yellow, it's the Goldilocks,
Yeah,
right? So the slam dunk perfect is 8 to 15, but that doesn't mean you can't bleed out of the edges there. So the 15 to 20, if you don't have evidence of cirrhosis, the platelet count is good, then absolutely, they're eligible for treatment.
Because my sense has always been, if you have a safe drug, it would be different if you have a drug that has a significant safety issue, is risk-benefit always. And if you have, even if you're not cirrhotic, if you're in the 15 to 20 range, you probably have a significant scarring burden in your liver already. To deny them therapy because is probably unethical.
And we have safety data on MASH cirrhotics who got semaglutide for another reason, small studies, but it's safe. You just have to watch for sarcopenia. Go ahead.
I think this is a really important point. We talk about these thresholds like they're set in stone. The reality is these are probability thresholds, and actually there are a significant number of individuals, exactly as you say, in that 15 to 20 window who are non-cirrhotic. They have significant fibrosis, and they're exactly the sort of people we should be targeting. Just the same with ELF. So I would go possibly even a little bit higher than 10.5 before I would deny somebody treatment.
All right, we got a bunch of questions.
Oh.
Let me just fire off.
Fire it off.
They're only the easy ones.
Rapid fire.
Yeah, you get 30 seconds now.
Oh.
Okay. Mastally with Hep B infection with undetectable virus load, LSM7, patient is on TAF, non-diabetic, AST is 78, ALT is 39, BMI is 25. Are we justified in any drug for MASLD in this patient, and if so, which one?
Were they overweight?
So this is a Hep B patient.
I need
Virus
to do a
load is
workup.
suppressed
Yep.
on tenofovir, but AST is 78, ALT is 39, BMI is 25, and has a liver stiffness of 7.
Check a PEth.
Yeah, we check a PEth, assuming this is all metabolically driven.
But the
You have two
KPA is 7.
different pieces of information. The AST is higher than the ALT, but the liver stiffness is 7. So you have to get some.
And this individual's thin, so they've got a high negative predictive value with that FibroScan that they don't have significant fibrosis. So I think you need to be thinking about other etiologies here.
Yeah, so
before
alcohol
with another
would be
drug.
very much an important one. But if you're really worried about the fibrosis, ELF test is an
Or
obvious.
MRE if that's
Or
appropriate, too.
get an MRE.
Yeah,
you
it's
know,
available to
which
you.
is the obvious way to figure out, which is a more accurate way to understand how stiff the liver is and how much scarring there is.
Yep.
But I would not make the decision just on this data. I would not pull the trigger on MASH therapy based on this data. Okay, how does the panel?
So Arun, on that, even if it was MASH, the KPA is okay.
That's why you
still
wouldn't pull
need
the
to
trigger.
validate
it.
You would not pull the
Yeah, you
trigger
need
on
more
therapy
information.
just on that data alone.
Yeah.
How much significance do you place on failure of improvement in transaminase? I think we addressed that, but a little bit, but maybe
I think
you can just formally address
I think
this
when we're
question.
thinking about therapy, we would expect to see a transaminitis improvement. If you look at all the trials, there was actually a very rapid improvement within about 4 weeks on individuals who were having therapy. So I think it is something I would be expecting to see. Maybe not in a 4-week time window, maybe a little bit longer than that, but it would be something I'd be looking out for. Mina, would you agree?
I'd be much happier if I did. It would just have me kind of crossing my fingers that I'm going to see fibrosis improvement in the absence of that.
Yeah, I think there's one question on GLPs and what could be the mechanism of their liver benefits in the absence of weight loss.
So that's an interesting question. I think one of the things we need to think about here, if we go back to the basic principles, the pathophysiology, why do we care about the fat in the liver that we can see? Well, it's not about the triglyceride, actually. It's about this invisible fatty acid flux, which isn't quantified. In just the same way, a drug like semaglutide, it's acting to reduce weight, but before it is even doing that, it's altering the lipid metabolism in the body, it's altering your de novo, that's very hard to say, de novo lipogenesis. So I think there's the potential for beneficial effects with many of these agents by altering that invisible fatty acid flux long before, and that would read through into
That would be directly
effects.
a function of improved insulin resistance,
Absolutely.
systemic metaboinflammation.
And in the heart trials, there was improvement in cardiovascular outcomes independent of weight loss. So whether there's any kind of vascular effects, endothelial cells remains to be.
Right. So another question. What are your thoughts on VCTE, IQR when interpreting the results? Should those cutoffs be decreased? How do you explain the poor correlation between FibroScan and biopsy results? I'm just reading the question.
Yeah, I mean, I like an IQR less than 20%, even though the textbook says less than 30%. I like 20%, and I question it if it's not that.
So it's absolutely important you interpret only quality FibroScan readings. So looking at the IQR over the median is very important. I use 25, so hey, it's somewhere between 20 and 30, but I go with 25 for that one.
All right, I have to push back, so I separate from both of you, because we've decided to do the study and actually look at this.
Yeah.
And?
So Richard Sterling, is he in the room? No, Richard's not in the room, but it's presented at AASLD this year. One of our fellows presented this.
Okay.
We looked at it by quartiles.
Yeah.
Turns out it didn't make any difference when we looked at in the NASH CRN, all the fibroscans, we looked at the interquartile range and correlated with histology. The error rate was flat.
It's interesting, isn't it?
So as long as you're within 30%, it seemed to be okay. But having said that, I agree with you. Sometimes when you do a fibroscan, within 30 seconds, you've finished your 10 exams, they're all clean, and you're done. And sometimes it takes a longer. So then I'm much more confident when I get all of the data, but that's just me.
Yeah. And the other thing to factor into it is in individuals with very advanced fibrosis, that IQR starts to go up anyway once they're in cirrhosis.
Yeah.
And so you've got to factor that into your thinking too.
Another very good question. Can we extrapolate the MASLD NIT data to MET-ALD who is now abstaining?
Say the question again.
Can we extrapolate MASLD NIT data to a patient with MET-ALD who is now abstaining?
I think it's a very good question. There's not a great deal of data yet, but I don't think there's any reason to suppose that it cannot be used. The important thing to remember is most of these biomarkers are looking at fibrosis. That's a common pathophysiological pathway within the disease. In an individual who's abstaining, what you're actually left with is a historical injury some time ago, ongoing metabolic risk. So there's no reason to suppose that wouldn't behave just like any other MASL patient.
So the way I think about it is, I think everybody thinks in a very static way that we put a label on a patient thinking this is it, right? But if you look at your own alcohol consumption patterns, we all sort of move back and forth, right? It changes all the time. And so you really have to think about in this steatotic liver disease framework in two axes. One is metabolic dysfunction, the other is alcohol. And I think people are moving through this all the time. And we need better ways of visualizing that journey, and to be able to relate that to risk. I think it's still an extrapolation. In the end, we have to be evidence-based in what we recommend. So while many of us clinically would say we extend and use it, that's because we don't have the data yet. Yeah. But I think eventually those data will come. And we have time for one last quick question. Pre-diabetic patient with mild CKD, hypothyroidism, and elevated liver enzyme. Same reversed with, the liver enzymes reversed with statin, I'm guessing. Ultrasound showed fatty liver. patient subsequently referred to specialists when enzymes became elevated again in a primary care setting. Is there anything that could have been done differently? So pre-diabetic patient, mild CKD, hypothyroidism, elevated liver enzyme, started on statins, liver enzymes came down. At some point, liver enzymes went back up, ultrasound showed fatty liver. And then that's when the patient got referred. Could something have been done differently, I guess?
Yeah, it's an interesting question. I think one of the things you might want to be thinking about is which statin have you used there? Is there an element of this that is being driven by the statins themselves rather than the underlying liver disease, particularly on a background of CKD? I guess that's one of the questions. But based on the information, I can't think of anything else. Mina?
I mean, a workup for abnormal liver enzyme should have been done before you start a statin. Like, why are the liver, I mean, what is the diagnosis there to begin with?
Yeah, I think that would be the key thing, that, liver enzymes are elevated for a reason. Absolutely. And even when you see fat, because it's present in 30-40% of the population, it may or may not be the only reason why liver enzymes are elevated. I think given that viral hepatitis has a very, very significant impact on patient health, and we have very good therapies for those, it absolutely behooves the patient in primary care to have first had all of that workup. And I think that brings us to time. And for those of you who are here, I just want to go back and point out over here that you can earn credit. There's the QR code over here, so you can get your CMEs. And hopefully, we've covered a lot of ground from the epidemiology of the disease, the mechanistic rationale for therapies, the therapies that are available, other targets that are under play, how you pick the patient to treat by using the NITs, focusing in on fibrosis, and when to use ELF, how to use ELF, how to use VCTE, the new data on the alignment of the cutoffs, and how to follow the patients. So really, in the clinical management, we're still starting with the FIB-4 of 1.3. And for advanced fibrosis, these are what the guidelines state. But we also talked about how we're beginning to modify, and hopefully the guidelines will follow the data when the next iteration comes in. And this is an evolving landscape. What we talked today is a snapshot, and this will continue to evolve. And so thank you for staying, and thank you for your participation.
Great, thank you. Excellent.